All right, thank you so much, Carrie. And it's nice to see that we have quite a few people joining us today. So I'm glad we have a nice group. I have been working with youth with Duchenne for not crazy long, but about over 3 years now. And prior to that, worked primarily with an oncology population. So I'm a psychologist who specializes in helping families through some very difficult medical situations of all different kinds. And I have a special place in my heart for supporting families affected by Duchenne. So today, and Carrie, you can kind of move us along here to the next slide. So I'm in Connecticut at the Yale Child Study Center, where in addition to my work in our muscular dystrophy clinic, I also am fortunate to work with many experts in trauma, and have learned quite a bit about medical trauma, which is unfortunately relevant to you all. So today I'll be talking about when the going gets especially tough, Duchenne and post-traumatic stress. Next slide, please. Just a brief overview of what I'll be discussing. I'll review what actually trauma is. I think it's a word that is bounced around quite a bit, so it's important for us to have a good definition. I'll give an overview of PTSD symptoms and how we think about that construct. And then I want to spend the bulk of my time talking about what you can do at home during and after a trauma, and then when possible, if we know something potentially traumatic is coming up, how we can prepare a child with Duchenne for that experience. And then I'll talk about effective interventions and provide you with a bunch of resources. So what exactly is trauma? Again, I think that people make assumptions about this word, but there's actually a psychological definition for it. So a traumatic event, we know, is a frightening, dangerous, or potentially violent event that poses a threat to a child's life or bodily integrity. Also, witnessing a traumatic event that threatens life or physical security of a loved one can also be traumatic. So we're thinking in this context about even separations from people that are unexpected, or witnessing a family member or a close friend, for example, experiencing a traumatic event. We know there's numerous trauma types in terms of abuse and other things, but of course the focus of today's presentation is really on medical trauma, and I'll kind of stay in that lane for this talk. What is crucial to take away from this slide as well is somebody can experience a traumatic event and not necessarily develop PTSD. And we know that there's a wide range of reactions after a trauma, and people are capable of being quite resilient in certain circumstances. So we don't want to assume that just because a potentially traumatic event occurred, that doesn't mean that somebody is guaranteed to have PTSD. Carrie, you can move us along. So some examples that apply, unfortunately, to the Duchenne population are things like invasive or painful medical procedures, being in the hospital, sometimes for a very, very long time, and particularly admissions to the intensive care unit can be traumatic, especially because patients are more likely to encounter really tough medical treatments in those settings. Of course, surgeries, and then we think about complex trauma, which is experiencing multiple traumas, sometimes over the course of a lifespan. Go ahead, Carrie. So I want to switch gears now and talk about trauma reactions. So what exactly is PTSD? So we know this is post-traumatic stress disorder. And rather than going in excruciating detail about what's defined in the DSM, which is our kind of our Bible of mental health disorders, I just gave an overview here, and I'll talk about each piece. So we know for somebody to be diagnosed with PTSD, there's often re-experiencing of the trauma in some way. So this could be nightmares, it could be having flashbacks, there could be things like what we call intrusive thoughts. You may hear a child or a teen say, "Oh, I feel like I'm thinking about that when I don't want to," or these thoughts just pop into my head even when I'm doing something completely unrelated. So you're looking for evidence that these images or thoughts are kind of holding the person hostage in a way, and they're repeatedly going back there in their minds. Avoidance is a huge factor that relates to experiencing a trauma and having PTSD. This could be this could show up in different ways. Kind of a classic way is behavioral avoidance, where a child or a teen or even a parent or family member is working very hard to stay the heck away from that thing that was traumatic, and to stay away from reminders of that traumatic event. So for our patients with Duchenne, if they've been in a very scary surgery or hospital or had a traumatic experience in a medical context, it would make sense that they would be trying to avoid hospitals or doctors, or anything that would even remind them of those things. And we also know, in addition to the action piece, the behavioral part of avoidance, we know that patients with Duchenne work very hard to avoid thinking about it or talking about it. Those are other examples of that avoidant category. And I speak to my patients about the fact that even though that is very protective and a normal response, what's actually going to be helpful in them recovering is learning ways to gradually confront those frightening things. And I'll get into that later when I talk about treatment. Another marker of PTSD is hyperarousal. We also think of how this relates to hypervigilance. And it's basically when a body has been amped up in because of a trauma. For example, we know when we're afraid of anything, our fight or flight response is activated. It's kind of like after a trauma that has never had the chance to deactivate, and it's kind of locked in the on position. So we see things like difficulties concentrating. We see an increased startle response. So for kids or teens, it could be something like, "Oh, I'll tap them on the shoulder," and then they really jump out of their skin. And then for hypervigilance, a classic example is kids really being quite paranoid or on the lookout for danger in a way that we wouldn't expect. And lastly, and importantly, we often see strong emotional responses, and this can look very different depending on the age of a kid and the specifics about their experience. So they could be sad a lot, they could be anxious quite a bit. Some people become significantly more irritable, and then thinking patterns and outlooks also change because of a traumatic experience. Medical examples would be things like, my doctors are trying to hurt me, or life isn't worth living anymore, the world is no longer a safe place. So the view of themselves and the future is drastically impacted because of a traumatic event. And for medical trauma, we know that it's often the case that people have a sampling of symptoms or a few categories, or maybe even just one or two. It's much more rare that people have full-blown PTSD even after a very significant medical experience. So I think that's important for us to hold in mind, that people can kind of tolerate a lot and move on from a lot, which is good news. Go ahead, Carrie. This is just a quick mention that goes with the slide before, and you're probably wondering why I stuck a lizard on this slide. The reason I did is there's a colloquial term for lizard brain, which is just our primitive fear state that is not, it's much more linked to our instinctual reactions rather than our rational thought. So with trauma, what's activated are these parts of the brain like the amygdala, which is where our fear response is really exists kind of in the middle of our brain. And then the hippocampus has to do with learning and memory. And then our prefrontal cortex is involved with decision making and rational thought and planning and problem solving. So all of these areas are affected because of traumatic experiences. So our amygdala really takes over. It's like our body becomes in this chronic fear response. And I just want us to be aware of that physiological activation and state. And that's why you might hear for a child who has been through a medical trauma, you might start to see some physical reactions to like sweating more or increased heart rate or more headaches or stomach aches, because pain is something that often follows in the aftermath of a trauma. So red flags that would be our telltale signs that, okay, a child is not recovering from a potentially traumatic event. What comes at the top of this list is an inability to move on. So if time has gone by, let's say months have started to go by and the child is still having some of these symptoms, and if they're not able to reestablish a normal routine, that would be a significant indicator that it's time to get treatment. We also are on the lookout for stronger reactions in response to what we think of as a trauma reminder. So a trauma reminder could be a sight or a smell or just an object or something that brings a child back to that experience. So once we see meltdowns or a lot of avoidance of those things or strong emotional reactions, and that's really atypical, especially when time has passed, like I said. And then lastly, we always are thinking about how much is a child or a teen's functioning impacted. Is this starting to get in the way of their friendships, or is this starting to get in the way of their ability to go to school or just get along with family members? So we look for that impact. So thinking about the road to recovery, so there is hope, and that's a good segue for me to talk about this next part. So before I move on, and we have our lovely chat function here, but I just want you all to think for a moment about a time that you felt frightened during either your childhood or your teenage years, but try to go back to your youth a little bit. And just put in the chat words that come to mind about what you needed from adults or what brought you comfort during that time. So again, I'm not interested in what exactly happened, but think of a time that you felt frightened and put a couple words down that come to mind about like what you benefited from or what you needed from people around you to help you through that frightening experience. Okay, Cheryl's saying open arms. Okay. And another response is that it's okay to cry and be angry. So a safe space to share emotions, even if they're difficult emotions. Others are saying a sense of trust, definitely words of comfort, warmth, comfort, listening, someone to listen. Yep. I love these answers. I'll let a few more come in and then I'll move on. Okay, I think that's a strong start. Yes, I think you're all hitting the nail on the head that we'll definitely be talking about themes of communication, safe space to share emotions, and understanding that it's okay to talk about it, and definitely strong adults who are able to comfort somebody. Okay, thank you for going there with me. Go ahead, Carrie. So this is not always possible. I felt like it would be amiss if I didn't comment on the potential for sometimes there's ways to introduce strategies that could make a child's adjustment to a hospitalization or something very scary easier from the get-go. So when possible, if possible, we want to plan in advance. We want to involve our teens and kids with Duchenne to in the creation of a coping plan. um, I do that regularly with my patients here at Yale. We actually write out a plan together of the steps that are going to happen and what they want to do to cope with each step. Even things like involving them in decisions about who is going to be present for different things can be really empowering and helpful. Um, for any traumatic situation, before, during, or after, we want to do the best we can to avoid secrecy and really clearly communicate. I think that was captured nicely in the chat. And we want to give sufficient detail, but it doesn't need to be all of the details about what's going to happen. And that will really depend on the age of the child and the developmental level of that child. So it's hard to get into too much detail there. Um, we want to give choices a sense of control. A nice trick that I talk about is giving something called a forced choice, where they have to you have to be okay as a parent or a caregiver with either option, but you can still offer a choice. So if they're going in for a scary medical procedure, you can give them potentially a choice about, like, okay, do you want to do it in your bed or in your chair, if that's okay with the doctor. So as long as you're okay with either, you can give some sense of control, um, and at the same time not overwhelm a patient with too many choices either, with which can raise anxiety. And then lean on the team. We want to involve child life. They're really experts in medical preparation, medical play. So I, even as a psychologist, I reach out to them quite a bit if I know that one of my patients with Duchenne is about to encounter something very scary at the hospital, like a surgery. And then involving other specialists as well. So this is kind of best case scenario when we have the time and the ability to do this. So let's talk more about if we don't. Go ahead, Carrie. So for this slide, I was thinking of situations like if a child is in the ICU, or if you've landed yourself in a critical medical situation where you don't have time to plan. To the extent that you can, I would still strongly recommend establishing a routine. Even if your child's in the ICU, there's a way to establish a routine of some sort, in terms of even things like how you structure your day, or when certain therapies happen. Um, at that level as well, let's say your child is so sick that it's even hard for them to communicate or be awake a lot during the day. We really want to focus on orientation. And what I mean by that is helping their bodies regulate about where they are, and also helping the child know what is going on at a basic level, and thinking a little more basically about things like, okay, how can we make sure that their sleep is somewhat regular, that they're sleeping at night and being awake during the day. So some of those things are within our control, even in these critical medical situations. To give a more detailed example, when I worked at St. Jude previously, when kids were in the ICU, there was concern about them developing something called delirium, which is a lot of confusion and mental status changes that can happen if you're in the hospital for a very, very long time. And we worked a lot there to make sure, for example, that they were as active as they could safely be during the day, which sometimes meant getting out of bed and sitting in a chair. Sometimes it meant, okay, we're just going to sit up a little bit during the day, or we're going to open the shades during the day. So again, we're really helping their bodies and their minds stay oriented, because it's kind of like you can enter this black hole of just time passing without a lot of awareness of what's going on and where you even are. So those simple things can make a difference. Supporting basic activities and establishing normalcy. So like, what are the things that they would normally be doing outside of the hospital? And are there pieces of those things that can be brought in? So is there a way that, for example, special comfort objects can be available at the hospital, or if there are things that they enjoy doing, whether that be books or video games or TV, like if they're able to, can that still be present at the hospital? If they feel up to it, would they be able to listen to a teacher say hi to them, or something like that? All of those things are not only helpful in normalizing, but they can keep somebody pretty distracted, and that aspect of staying somewhat busy and having things to look forward to can really help coping. I already talked about leaning on the team and the specialists that are great at what they do for support. We still want to involve a child or teen in decision making and their treatment plans. To that end, though, we want to be mindful of how much information is shared. I think that there are circumstances where, because there's so many medical conversations going on, sometimes kids hear pieces of things that can be very, very frightening. So just being aware of where and when are those conversations taking place, and what parts need to stay with the adults and what parts can be shared with the kids. I think planning with the team is important there. And then don't be afraid to advocate for your child, because of course you are their parent or caregiver and know them above anybody else. So once you have learned ways that they are more comfortable in the hospital or in a very frightening situation, please share that with others who are caring for them. So moving forward, I want to start by saying here that kids and teens, especially younger kids, are usually quite pulled to return to normalcy. And sometimes that can be a little alarming to adults. And again, this is kind of best case scenario when, let's say, the medical trauma or the traumatic event of whatever kind has been in the past. Sometimes adults get a little concerned and confused if it seems like, wait a minute, like they want to go back to school or they want to start talking to their friends. If that happens, that's good, and we want to encourage it. So this is to acknowledge that sometimes parents and kids can be on very different pages with how they've experienced a medical trauma and what they need at that point in time to move forward. And that's pretty normal. We know that traumatic events are very subjectively experienced, and it's actually not so much about like how potentially lethal or serious the medical trauma is. It's not really about that. It's more about how somebody has subjectively went through that themselves that predicts whether something like PTSD would happen. So I again can't emphasize strongly enough that the reactions and the resilience are so varied, that it's okay if you're not lining up with where your child is. You'll see this theme here that continues. We do want to keep normal routines to the extent possible, and on that note, we also want to set the same limits as you normally would, even before a medical trauma or a serious hospitalization or whatever it is. And what that does is it actually sends a message to your kid like, we are going to be okay, and I have confidence that you can handle these same things being a part of your routine. So that sends a message of empowerment. The alternative would be if we pulled back too much on those normal limits and routines, then it's that can accidentally become a trauma reminder because it's sort of like sending this message of, now I think you're fragile and you can't handle this. So just maybe that reframe can help some people in this group if they feel pulled to a place of overprotection. As you all mentioned in the chat, we want to think about offering opportunities for a child to share and communicate. This also varies quite a bit depending on the age. For example, for our very young children, they often resolve conflicts and process traumas through play. So giving them things like toy hospitals or ambulances or you know, medical play objects, which do exist. That's one way to help them process what they've been through. And then for older kids and teenagers, they're a little more prone to withdraw and not necessarily want to talk about it. So we have to approach them in a way that is sensitive and looks for those openings, but is not overly demanding that they'll talk either. I think some kids withdraw more when there's an expectation or a pressure to talk more about it. So I think of it as being available for those conversations, finding ways to kind of sidle up to a teen and ask a couple open-ended questions. And then if they don't want to talk about it in that moment, then that's okay, and we're not going to badger them. And then, as people said before too, like, we can expect this range of emotional responses. It's okay to normalize and to really let people know that the reactions that can happen after a medical event like that are so diverse, and it's okay for that child to feel what they're feeling. And we can have the peace of mind that most of the time those responses will become increasingly less strong as time passes, and if they don't, then we'll think about professional help. As I mentioned earlier in the presentation, going through a medical trauma can really change a person's worldview. And as you're talking with your child, if you're hearing things that we call like a thinking mistake or a cognitive distortion, then we can help them gently challenge that. So you're looking for that black and white thinking or that catastrophic thinking. You're looking for statements that show that they have kind of an altered view of the world, and rather than just shutting it down and saying something like, well, we know that's not true, or you know, or something to immediately correct it, you can just help them kind of pick that thought apart together and be like, huh, like, that's interesting that you said that, tell me more. And, you know, do we think that thought is the reality? You know, is there a different way of looking at this? I think that's different than just being quick to correct someone or quick to reassure. We really want to help guide a child to that instead. This is a very difficult one, this next bullet, but to the best that you can, try to avoid some common parenting pitfalls that follow a trauma. I'd say the biggest one that I encounter, especially in the Duchenne community, is overprotection, and that comes from a place of love and looking out for your kid, and at the same time can sometimes keep them in this very anxious place. So just being mindful of that. Most importantly, as well, we want to protect time for self care. And whatever that looks like for you, whether that be talking to a therapist yourself or just protecting time for exercise or things that you enjoy, it's very, very crucial. We know that even if it was only the teen or the child alone who really went through something personally, it of course still affects their family. So please take care of yourselves. And then be aware of potential trauma reminders, especially during times when there's a strong emotional or behavioral reaction and it seems to come out of nowhere. We often find through a little bit of detective work that sometimes there's something that seems quite benign or unrelated, and then there's a way that a child really actually is remembering something that happened at the hospital or a scary medical procedure. So sometimes you have to dig, but we can occasionally find a trauma reminder there. Again, I think once we're at the point where it's clear that symptoms are not reducing and a child remains in this activated, traumatized state, it's really imperative that you get professional help at that point. There's lots of different treatments that people advertise for trauma. I'd say some things like art therapy and EMDR, which is eye movement desensitization tree reprocessing or something. Those two are thrown around as good options, but what has the best research support is something called trauma-focused cognitive behavioral therapy, or TFCBT. This is the gold standard treatment for trauma for youth. And it's been used effectively not only for medical trauma, but for patients who, or I shouldn't say for patients, for youth who have been affected by things like 9/11 and Sandy Hook and all these other disasters. So it has really, really strong support for all different types of trauma types. And you'll know that you're in a good trauma treatment if it's family focused. Again, this is not something that only affects the child. And exposure based. And what I mean by that is there should be an element of re-experiencing a trauma in an organized way, kind of intentionally. And the purpose of that is to help kids develop a new narrative and a new way of thinking about the trauma that helps their coping. So I'll give a concrete example. A big part of trauma-focused CBT involves, towards the end of treatment, helping a child write a narrative or kind of their story about their traumatic experience. So if a patient with Duchenne were to go through this, they would be constructing a story, like kind of a timeline of like, this was life before, you know, this medical event or this surgery or whatever it was. And then they would write in detail about that. And they would talk about their feelings, and they would talk about kind of the play-by-play of what happened. And then they would talk about life now, which allows them the opportunity to formulate a perspective that's helpful. And then there's a part of that treatment that also involves helping that person share that with their parent or their caregiver, so then both can process that together. So in a way that they're really supported, they're going back in time and thinking about these things and getting support and communicating about them. There are times when psychiatry services are warranted. We want to think about that as well. And then lastly, I don't have time to talk about it in depth today, but it's often important to consult with the schools, especially when a child's been diagnosed with PTSD, because some schools need help thinking about how to support them when they have those symptoms. I also, as I near the end here, I wanted to talk just very briefly about this concept of post-traumatic growth. This is a term that goes along with our thinking about resilience. And there's some very interesting research coming out that's been done with lots of medical populations. So kids with all sorts of terrible illnesses. And what we've learned is for both kids and adults, there's often some surprising positives and personal growth that can come from living through a trauma. And it can change their philosophy of life, it could change their views of themselves, and it can positively impact their relationships with others. I really like to acknowledge this because there's increasing research to show most people get through horrible things in a way that, yes, is extremely challenging. And usually we can find some silver linings from those experiences. So I think I really liked this diagram, and I think it's something for us to remind ourselves of too. So to end with some resources, by far my favorite resource and the one that seemed to have the most on medical related resources is the top one, the National Child Traumatic Stress Network. If you go there, I mean, first of all, they have tons of resources for anything. Like they even had information about talking to kids about what happened at the Capitol, for example. But if you type in medical trauma, they have a plethora of like handouts and toolkits, like how do I help my child cope after coming home from the hospital. There are caregiver guides, there are provider guides, there's just a ton. So in your spare time, I'd recommend perusing that. You'll see they're all very organized and have some nice pictures, and really parallels what I talked about today. The Child Mind Institute talks about trauma more generally, but still relevant information. And then I liked, I think the website doesn't really represent what's in it, but the Critical Illness, Brain Dysfunction, and Survivorship Center had some nice medical resources as well, and had some good ideas for how to support kids during an ICU admission, and what to do to support them when they come home. And then lastly, this was a nice book that I like, A Parent's Guide to Building Resilience in Children and Teens. There's a website where you can actually search for trauma-focused CBT therapists who are certified throughout the country. And then we use this book a lot in my clinic. It's called A Terrible Thing Happened. And what I like about this book is for kids, it illustrates very common trauma reactions in a nice way. And in the book, it never reveals what this little raccoon or whatever he is, whatever his trauma was, it doesn't get into that. So it can apply to any trauma type. I've even used it as a starting point for discussion with teenagers as well. So I like those resources for families too. And on that note, I'll take any questions, and I think I have about 10 minutes to do that. Happy to talk more. And there's my contact information before if anybody needs to email me afterwards.
Thank you so much, Paige. It's always such an awesome presentation. I like how we're able to take a topic like emergency care and look at it through a couple different lenses back to back. I think it's really useful. I'm going to go ahead and start some questions for you.
Okay.
So Cheryl's asking, would you recommend reaching out to friends' parents to let them know? I assume this is kind of going with re-entering back, after a hospital stay or an emergency.
I think that's a great question. And it sort of depends. So I think what immediately comes to mind is you would want to involve your child in that decision, especially depending on the age of a child. So, if you have a 5-year-old, then it would kind of make sense for you to do that. But if you have a teen, they might be thinking, they might have a very strong opinion about who they want to know what at what points in time. So I'd involve your child, but I do think there's times where that would be very appropriate.
Right. Thank you.
Great question.
Feel free to continue to put questions in the Q&A box, whoever's on the webinar. I have a question for you. I was going to see, you talked about how you make a plan with some of the kids you see, and that's obviously in a situation where you can make that plan, but I'm wondering if you recommend, any other, if you don't regularly see counseling, would you maybe pre-schedule an appointment to kind of have that sort of one-on-one counseling prior to a surgery?
Yes, yes. I think definitely. I think you definitely could do that. I've met with people myself for that same reason. Again, depending on their availability, if your child or if your child's hospital has access to child life specialists, they are experts at doing this as well, at medical preparation. And they do some really creative things. I've had patients of mine, for example, be able, I mean, it's harder with COVID, but they've been able, for example, to like see the room that their procedure is going to take place in, or they'll be able to like hold pieces of the equipment as long as they're safe. So they do some nice exposure stuff to take away the mystery and make it less scary. But I think that could also be done with a counselor too. So yes, I think that could work. And I see, Cheryl, you had another question. What do you recommend for parents to keep patience while the child is coping with the PTSD? I think that's a good question. And let's see, to keep patience, can you, maybe Cheryl, can you clarify what you mean by patience? Like, are you referring to a parent's ability to cope during that time and self-care? Or are you more curious about the length of time that the symptoms are lasting and how to be patient with that? I just want to make sure I'm answering the part that you care about. Yes. Okay, I'm glad you clarified because that's different than what I was thinking. Okay, so understanding of what the patient is perhaps acting out. Yes. And I think you hit on a good point there that I didn't really get into during the talk, but symptoms of PTSD can often look a lot like something else. I think sometimes they can look like ADHD, or they can look like aggression or disruptive behaviors that maybe were not there before a traumatic event. And these can be really confusing for any adults that interact with the child, especially if they're out of character. So I love that you're thinking about how can we be sensitive around that and be patient when we're seeing behaviors that are more challenging. And I think this is where these are types of situations where working with a professional to help figure out like, okay, what is related to the trauma and maybe what is more related to the developmental stage of that child or something that was there before the trauma that's getting stirred up. I think without knowing the situation, it's tough to know, but I'd encourage maybe getting a professional's assessment of what's what there. But for being patient, I think also leaning on other supports too, if you can, to kind of share the load with that.
Thanks, Paige. And I just want to piggyback off of that. I think something that goes, not talked about is siblings within the family. Yes. So if you could maybe just speak to some strategies to communicate to their siblings about what is going on, and maybe some of the behavior associated there.
Yep, absolutely. Yeah, thanks for bringing me there, Carrie. So I do think you're right that we can have people go through it, as I said in the beginning, a traumatic event that affects them, and people can develop PTSD by having somebody else close to
Looks like Paige
Oh,
froze for just a minute. Sorry, Paige, do you mind just jumping back just a few
sure.
seconds? You froze for a second.
Sure. Yeah, sorry about that. So, am I still there?
You're still
I'm
there.
getting
I see.
I'm getting a message now that my internet is unstable.
Oh no.
So
Great.
I think you're right, Carrie. And what I was saying is in the beginning, I did talk about that you can develop PTSD even if it's not you that went through a potentially life-threatening thing. So for siblings, as hard as it is, we do want to be honest with them. I think depending on the age, for little siblings, it might be saying something very basic like your brother is very sick and is in the hospital and has a lot of good doctors taking care of him. For young kids, that might be sufficient. For older kids, get ready for a lot more questions. And I think to the extent possible, protect some special time that's just for them. Obviously, if a child's in the hospital and that puts a tremendous amount of stress on the entire family, and it's hard sometimes to find that extra time. But think about some ways that you could build it in, or at least acknowledge to the sibling, like, I know this is a lot, and I know it, I would own up to the fact, like, I know I'm not able to be here for you as much as I would like to be, is one nice way to say it. Um, and siblings do tend to, in these cases, sometimes um, get pushed to the side, and I think that's very unintentional when it happens. Um, I think some siblings, not all, like to be involved in some of the medical conversations, or they like to be in the know, and others do not, and that's okay too. So I'll give you an example. I work with one family, and this young adult has Duchenne and is unfortunately not doing well, and the mother is quite frustrated that a sibling of this patient is kind of not interested and is off doing his or her own thing in life, um, and we have to be patient with that part and understand that that might be how that sibling is taking care of themselves through this. And even though from our adult lens, there's a lot of urgency to like swoop in and be there for the identified patient, um, that's not where everybody's mind is always at. And that's not necessarily every family member's style or need in that moment. So for siblings, just again, like we want to give them a little extra attention when we can, and also understand that their reactions will be very individualized.
Right. Thank you, Paige. I know that this is a topic we could probably talk about for a lot longer, getting out into the sort of network of the family, but that's all the time we have for today with you. So thank you so much for joining us. This was an awesome presentation per usual. And then, as Paige said, her contact information is up in this presentation. It's recorded and it'll be available to you all. So feel free to reach out to us or Paige if you have any more questions.